Um, Hi, I'm not sure if it's morning or afternoon or evening to anybody who's watching this session, but this is a recording that we've designed to be an open discussion forum. We've got experts in the field of aortopathy joining us today because the topic we want to focus on is how we actually assess the aorta, particularly when we're thinking about sizes, indexing, but how that fits into the clinical context and what our echo reports offer in terms of clinical management for patients. I'm joined today by Dr. Yaso Emmanuel, who is an ACHD cardiologist at Guy's and St Thomas's, but also an aortopathy doctor, so very familiar with this area of expertise. And I'm also joined by Professor Dave Oxborough, who's a professor in echocardiography and cardiovascular physiology in Liverpool. So Dave has a special interest and lots of knowledge in relation to scaling. His understanding of BSA and also indexing to height is, beyond most of the people in our area. So we welcome both of these individuals to this discussion. I guess to start things off, Dave, is it possible to provide us with a little bit of history in terms of how in the past we have been looking at the aorta, the measurements we were performing up until, say, the last decade?
Yeah, absolutely. Thank you, Kelly. Yeah, it's an interesting one, really, because if you look back at the data and look back at the literature, the American Society guidelines in 2015 was still drawing upon a 1989 paper by Mary Roman, which included 150 patients, and they utilized M mode. And they also looked at the maximum diameter, and they used a leading edge to leading edge technique. Since then, there's been plenty of work, but it's all pretty heterogeneous and a bit disparate and not very clear populations. And so we did a study back in 2014 with the BSE, which was just to look at the methodology around what might be the most reliable, most reproducible, and probably the best way forward. And it found that the most reliable was inner edge to inner edge and end diastole, because of where the end diastolic component is. So this was the norm, and scaling really wasn't, well, it was, but to body surface area. And then NORA was published in 2016, I think, or 2015. And NORA utilized 700 participants, 800 participants, and they published data which included the scaling to height. And this is the data now which the BSE guidelines, the 2018 chamber quantification guidelines, utilize. So our requirements or suggestions are to measure inside edge to inner edge, in diastole, and index to height.
Lovely, thank you for that. And for those who are not familiar with the NORA studies, what we can do is we can provide a link to that information so that that's available. It was a European study. So I guess in some respects, we also need to think about the validity of that data in relation to our population within the UK. So thinking about what Dave's said, in that previously we were looking at absolute values and now moving to BSA and scaled data. If you put that into the clinical context, how successful do you think that we've been in terms of predicting dilatation of aortas and those patients who require further follow-up and management?
Thank you, Kelly. I think it's a little bit difficult to kind of quantify that, because it's generated a very mixed bag by diagnosing a lot of people with dilation, and we have to sort of go back to thinking, what are we actually trying to do when we're doing the scans, and what are we trying to identify, and what are we trying to manage? And if you look at the management guidelines for people with aortic disease, they still use largely absolute values of 4 centimeters and above being dilated. And even if you look at the guidelines for how do we perhaps, or the pathways for how do we identify people who've got aortopathies of significance for potential things like Marfan syndrome, connective tissue disorders, they're still on Z scores that are above the kind of numbers that we're getting based on the NORA data. So they're looking at Z scores of 2.5 and above. So the management guidelines are still using data that's well above there, and that's based on collective expertise and literature as well in terms of the clinical significance. So I think it falls between what's academically dilated because it's fallen above what is been defined as a normal population, and the difference between that and what is dilated because we see that that's a dilation of which something is significant. And they're not the same thing. So something may not necessarily, maybe above a normal range, but it is not indicative of pathology and it's not likely to lead to anything. And that's where we've got the real challenges of people who fall in between the two definitions. So they're not what clinically is deemed to be dilated according to management guidelines, but they're dilated according to echo guidelines. And that's where we're having the real issues, if you like.
Yeah, well, I think that many of us recognize that when we do report out these findings and that we're calling aortas dilated, that is going to lead to increased pressure on resources. But Dave, how do you feel about this? You know, you're doing an echo, the numbers are suggesting that the aorta is dilated. You know, how are we best to report that?
Yeah, I mean, there's a couple of points here that we have to. We're basing it on a normal range, and we have to, I think, as echocardiographers, we have to report whether it fits within that normal range or not. And therefore, we publish that range, we highlight that range, and we say it's above this value. I think it's very important to not only report scaled values, but also absolute values, because Yaso's just mentioned very clearly that the data for thinking about development and outcomes is primarily dependent on that. So I think we report the value. I personally think that you would say it's above the normal range for this. How that's dealt with afterwards is more challenging.
Yeah, and I think that that's a really important point. And I think this is not the only time that communication has become a key component that kind of links the echo report with the clinical management of the patient. So I think as echocardiographers, we really need to think about how we're communicating this patient. Yeah, so you probably see a lot of these patients who are who read their echo reports and find out by surprise they've got a dilated aorta. What do you think the consequences of that are?
Well, sometimes it can be very challenging because we live in an era where the first thing everybody does when they see something is abnormal is they go straight to Dr. Google. And if you put in dilated aorta into Dr. Google, if it links you to all sorts of stuff about aortic aneurysms, then it generates a lot of alarm in people. So we have to be very wary of that and aware that that does generate a lot of anxiety. And many people may not be necessarily, they would be more happy to be guided by the clinical teams, but there are a lot of people in whom they get a report, or the GP's sent a report that says this is dilated, and then the patient goes up and says I'm at risk of aneurysms, I've got an aneurysm. They feel the patients don't necessarily always understand the difference between dilated and aneurysm. And so in their mind, dilated equals aneurysm, and they feel they've got an aneurysm and they need to be seen urgently. And then even when the referral is made, we get a lot of people then still phoning us saying, I've got an aneurysm, I need to be seen urgently, even though it may not be that dilated. And so it can create problems. It's not easy to solve, but I think it's important that we at least raise awareness of the consequences of how things are kind of interpreted by the patients as well.
For sure. Yeah, for sure. I think that that's a really important point. And it's not just the consequences for the patient either. So I suspect you and your colleagues are getting more and more of these referrals in your clinic, and then we have to think about resources.
That's the real challenge, is resources. And, you know, in an ideal world, we'd have endless resources and we could see and reassure everybody urgently. But unfortunately, we have to live in the reality of what we have nowadays, which is endless waiting lists and, you know, people who need to be seen. We have to prioritize how urgently we see people. And people, if they don't get an appointment for a long time, feel very disgruntled. And so it becomes, it's one thing that we have to be very aware of. You know, one thing is the academic purity, if you like, of what we do, and what we label, and then how do we actually translate that into the reality of our NHS resources and preserving the priority of access for the people who need to be seen urgently. And that is the challenge. But I think it's the first step is raising awareness of the balance of all of the demands, in the first instance, and to make people aware that you've got to think out, not beyond just what the immediate next step is, as well, and down the line.
Can I add something, Kelly?
Yes.
Yeah, I mean, this is the challenge for, going back probably to your last question, really, to me, was around how that should be reported. And one of the things that we have to do, I think, is recommend follow-ups and think about triage and whether that patient should come back in 2, 3, 4 years' time or not at all. And I guess that's dependent somewhat on the data and what we know. And if we look at progression of disease and particularly in the aorta, it's based on absolute values. So we know at 40 there's appreciative increase and exponential at 45, and we know the progression increases. We currently don't have the depth of data for scaled values. So I think we will, when we do, and if we do get that data, which I hope we will do, then that will help to provide a more size independent, accurate measure of the aorta relative to an individual, and to establish the progression of that disease, which then can later inform whether we need to follow up and see them more frequently or not at all.
Well, I think that's a really good point. One thing I was going to ask about scaling is, I noticed that in the recent American 2022 guideline, they do reference absolute, but also indexation, so to height and both BSA. But then in the more recent 2024 guidance from the American and European group, they've gone back to absolute. For me personally, I feel as though scaling, and particularly scaling to height, makes a lot of sense. So it feels a little bit like a step back. Do you have any thoughts on the absence of this in the most recent guideline?
I agree. I think it does feel like a step back, but I think we're of the understanding that these guidelines are developed based on evidence base, on consensus, and because there isn't that long-term data, there is some data, and it is there in terms of demonstrating that index values do have, particularly when they're indexed to height, so a 40 millimeter aorta in a 1.4 meter person has a 12% risk of an event, whereas a 40 millimeter in a 2 meter has a 4%. And this is only one study in 700 patients. So there is some data, but not the volume that's required. So I think that's probably why the change is there, because the volume of data and evidence isn't available. But going back to your earlier point, that scaling is the way forward, in my opinion, because it's taken into account the demographic of the patient, and we do know that there is a linear relationship between height and an aortic size, and so it's very easy to divide by that to get a size independent index. That relationship to body surface area is non-linear. So if you divide straight by body surface area, you're not going to get a size independent value. Plus, we also know that body surface area takes into account body mass. And if there's fat mass is not going to drive cardiac output. So that that it changes the values significantly and makes them less accurate.
Thank you. I think that for those people out there who aren't using scaling, that was a really nice explanation of the value of it. I guess my next point is, we're not treating the echo, we're treating the patient. So we've got this dilated aorta, and we've talked about the rate of progression, but what other parameters are we really thinking about when we're deciding whether that aorta needs further management or follow-up?
So I think so there's a lot of other factors that we take into account. It's the overall clinical assessment we make of the family history, what dissections there might have been in other people, what other phenotypic features there are in the individual patient, and rate of progression is also another feature that we do use. And although the latest 2024 guidelines may seem to not place as much emphasis on scaling, what they have tried to do is actually embrace some of the kind of wider picture that we use when we're making decisions about surgical intervention, about individualizing it more to that particular patient. And what's also interesting is that the guidelines have also include shared decision making with the patient in the guidelines specifically, to say it basically in recognition that it's not quite as absolute, and we have these thresholds, but they're not set in stone, and we do individualize it more, and we're more comfortable as time goes on discussing the kind of grey zone, if you like, with patients, because when we're doing surgical interventions in aortic disease that are on for prognostic indications, it is purely for prognostic indications, and it's a major thing undergoing surgery. So it's very much shared decision making. It's not quite as paternalistic, and the point at which you decide to undergo a prophylactic operation it's not always straightforward. And yes, if it's clearly dilated at 6 centimeters, it's a bit more of a straightforward thing. But there's a bit more grey in terms of the point at which you actually say yes, and it's actually more of a discussion between the patient and the surgeon. It depends on their individual surgical risk, the surgical approach, how anxious they feel. There's a lot of other factors to take into consideration. So that's what the new guidelines have also tried to incorporate and promote, is an individualization of the whole picture in a discussion with the patient, rather than just making it binary. Your number is this, you don't need it. Your number is this, you do need an operation. So that's the sort of discussions that that's the kind of trend and the direction, is standing back and looking at the bigger picture with the patient.
Brilliant.
Can I quickly add as well?
Yes.
So I think this is also important, and just going back to exactly what we're saying in terms of the bigger picture in the individual, is that older individuals have a very different relationship in terms of height and aortic size. So we know that as you get older, you do lose height, and that's usually due to musculature, not skeletal height. But you do lose height, and the aorta gradually increases, and we know from less than 40 to over 60 you can get a 5 millimeter increase in the aortic size just through age alone. So I think the scaling part and thinking about going and what you're going to do with them in an older individual over 60 is more challenging, and I think that's where the absolute values are probably better as well. So you may well, if you see a 45, 50 millimeter in an older person, then that probably needs acting upon, rather than something of 35, obviously of 25 millimeters per meter squared.
Good point. I think I think your perspectives are very much aligned on this. I think that you're both saying that scaling is important, the absolute values are important, but putting it all together with that individualized patient perspective is also key. Just to finish off with, I guess I just want to know, what are the solutions? So I feel as though we're left with this cohort of patients who need to be followed up. They have disease, they have all of these risk factors. We must capture them. But we've also got this population of patients who maybe we're slightly over calling and they're having unnecessary follow-up. What do you guys have any comments on how we might be able to get this right? How can we do it better?
That's a really challenging thing. It's going to take us a consistent education process, I think, and we have to start somewhere. I think if we boiled it down to sort of simple take-home messages for the kind of red flags, if you like, I mean, the ones that really, according to the guidelines, need to be referred, or certainly if it's 4 centimeters and over, then that should be probably followed up and assessed. For the ones that are under 4 centimeters, the ones that we're really interested in seeing are the ones where there's a real family history of thoracic aneurysms and dissections. Those are the kind of red flags. And certainly I can provide you links for you to put on there for some of the pathways that we can use for assessing who should be referred for a thoracic aneurysm, hereditary thoracic aneurysm clinic assessment, because that'd be helpful for people to see as well. And bicuspid valve disease, sometimes if it's just associated with a bicuspid valve, that can go into valve clinics, because even if the aorta is not particularly dilated, if it needs follow-up for the valve, we can follow those up in those clinics. So there's a variety of things that we can, of education avenues that we can promote to try and improve people's kind of thought processes as to thinking as to what's actually going on.
Dave?
Yeah, so for me, I'm going to take a step back and say methodology, quality, standardization from an echocardiographer's perspective is absolutely crucial. So ensuring that you're getting the best windows, ensuring you're making the correct measurements in the correct place, and you're adhering to the BSc guidelines. Really, really important. I think we have to report absolute values, and I think we have to report scale values with the caveats that we understand and that we understand around scaling. The same with absolute values and their caveats. And then it's about communication and education, and that means everyone who's involved in the whole multi-professional disciplinary pathway, the cascade of the patient. We need to be around a table, and we need to be talking about what standardized nomenclature, values, whatever. It needs to be standardized so that we and everybody, that means everybody around that table, know what everyone else is doing and how best to report that and communicate it. Webinars, maybe. Webinars are great. Educational documents. These things that we're doing, the meeting now.
Well, exactly. I think that's really important. And I think even the most, the 2022 and 2024 guidelines have really supported the value of aortic MDTs. And I think that when you have those people at that table and that level of communication, the messages that you're sending are much clearer in terms of what that information means. I think some key things that we've pulled out of this is just that, as echocardiographers, we need to be careful in terms of the information that we're providing and how we report things out and how that's then put into the clinical context. So I think talking to your teams and having consistency within the group is key. We also need to think about putting that echo result in a group of identifiers for that patient. So, thinking about their risk, thinking about their progression, and only then is it something that might be valuable in terms of future management for that patient. I just wanted to finish off by saying thank you both so much for joining us. I think that your expertise and input has been phenomenal, and those who have the opportunity to listen to this short video will really appreciate those expertise. So thank you very much.
Thank you, Kelly. Thank you, Yaso.